Hello and welcome to our Kinepict Knowledge Base Podcast. I am Krisztián Szigeti, CEO, co-founder at Kinepict. Today, we are happy to welcome Dr. Leona S.Alizadeh from Institute for Interventional Diagnostic Radiology, University Hospital, Frankfurt. Hello, Leona, and welcome.
Hi, everyone, and thank you very much for the invitation. I'm very happy to be here today.
Please introduce briefly your institution. What is your major profile? What kind of intervention do you make most frequently?
So I work at the University Hospital in Frankfurt, and as a university hospital, we have many different types of interventions, but our biggest focus in everyday work is on interventional oncology, like transarterial chemoembolization, transarterial chemoperfusion, ablations, and we do a lot of different kinds of CT interventions. And so at the moment, we are also developing minimal invasive treatment of prostatic artery embolization and for benign prostatic hyperplasia. So we have a bright and wide spectrum of different interventions.
And how did you hear about the Kinepict technology, Digital Variance Angiography as DVA? How did you get in touch with Kinepict?
That's actually a funny story because initially, I think it was by the end of 2017, so a few years ago, when Professor Vogel was introduced to the software more or less by accident, because we were at a conference and we got to know the software and Kinepict for the first time. And back then we haven't heard about the company so far, and we didn't know about the technology. So when I heard about the technology, of course, I was at the conference too, and I was very eager to learn about it because it showed a great potential. But I think back then it was already, you were already present, but it was like a initial phase of the implementation of Kinepict. So I was very happy to be one of the first to actually get in touch with your company to do scientific research.
Okay, and which topic was a part of the research collaboration?
So I think back then we started in 2018 with the first patients, mainly abdominal DSA series from different interventions. So for the procedure types, we had transarterial chemoembolization and also later different kinds of interventions. We did peripheral angiography too, but we quickly learned that one of our main focuses was on the abdominal and pelvic region. So basically we started out with the prostatic artery embolization because back then we started also doing the procedures, and it was a nice fit for the software.
And what are the most important results so far, and what is the significance of this data?
Yeah, so definitely the most important part was the quality reserve, which we could observe in the DVA in contrast to the DSA, and the better visibility of the small vessels, and even at low dose. And also we have many obese patients or oblique view angulation of the C-arm, where we need the best possible image quality, and that was definitely a game changer for us.
Have you already published your data?
Yes, we did a recent publication in academic radiology, and it was an initial investigation on the prostatic artery embolization. And it was a retrospective trial. So we just recently published it this year.
Okay, and what is your general opinion about DVA? Can you highlight what is the very difference about the clinical practice compared to the classical DSA?
Yeah, I think for us, the highlight was to have the clear contrastation of the small vessels, which we sometimes lose due to the dilution of the contrast agent in the small vessels, or due to the flow. And I think that's one of the major aspects, because especially in prostatic artery embolization and also in other interventions which we do at our institution, it's very important to rule out that you have a cross flow of embolic agents to other organs, and that definitely was one of the most important features.
A lot of times you highlight a prostate embolization. Why? It's a new technology in the intervention, or do you have a lot of very interesting results if you see the other doctor, or why?
Exactly, yeah, it's basically both. So it's a new exciting intervention, so it's upcoming, and we have more and more patients who would like to get a prostatic artery embolization, and then again it's for benign prostatic hyperplasia. So we don't want to have a high radiation burn, which is basically one of the major concerns, which is stated throughout the literature in context of this procedure, also by urologists. And I think this is such a nice field for application of this software, because we are able to save radiation dose at the same time without losing the image quality. And you really want to make sure that you just embolize the prostatic artery, not the vesicalis artery, and harm the bladder or have a cross flow to the rectum. So it has a high clinical value and also patient safety aspects.
Mm-hmm. The Kinepict workstation has been installed on your cath lab. What kind of angiography system do you use?
So we are lucky to use the Artis Fino system, which is a rather new system by Siemens Healthineers. And so the image quality was very good initially, but when you go to a very low radiation dose level, and we still see a big difference. So we had a high quality reserve in our trials.
As you know, the Artis Fino is a very, very good machine. And what is your experience with the DVA in your daily work?
So in the beginning, it was we had concerns that the images didn't load so fast, or the displaying was like a little bit delayed in the everyday life during the procedure. But basically the progressively faster post-processing of the images, which is really getting updated by the software updates from time to time. And by now, I think we have a very fast calculation time of the images. And during the interventions, we like to just have it as an additional image next to the DSA image on a split screen on the Angio suite. And we also do a lot of color-coded DVA imaging to assess the flow. And so that's basically how we use it in a routine, and mostly for routine interventions. So we don't use it so much in the emergency cases or in special interventions where we need the whole angio display to display, or roadmap images and so on. That's I think something for the future, but at the moment we use it for routine interventions.
Mm-hmm. Are there ongoing studies with DVA?
Yeah, we fortunately have several other studies which are upcoming at the moment. We have trials on abdominal imaging, basically on transarterial chemoembolization, which is one of our most frequent procedures here. And also we would like to try it in the context of transarterial perfusion, chemoperfusion, and also for transjugular intrahepatic portosystemic shunting. Because we would like to try and play a little bit with semi-quantitative analysis and to test if we can save some contrast agent, especially for these patient cohort, which is really sensitive to kidney failure. So we don't want to have a high burden of contrast agent.
You mentioned the CCDVA. Do you have previous experience with a similar iFlow product from Siemens or not?
Actually, iFlow, we never really used iFlow at our department. I've seen it several times, but we basically started using the color-coded DVA because it's just one click away, and I think it was natural to use it side by side with the standard DVA and additional to the DSA, but we haven't used the iFlow in our department.
Okay. I would like to take the opportunity and thank you again for participating with Professor Thomas Vogel in our Kinepict Symposium and Thursday. Could you kindly share some part of the presentation and findings?
Yeah, thank you indeed for the invitation. It was a very interesting symposium, and it was very, showing new frontiers of the use of the software, and we were very happy to take part. And during our presentation, we basically presented our results from a retrospective trial on the PAE, where we had more than 2 times a signal to noise. I have to start over. It was contrast to noise. Thank you indeed for the invitation, and it was very nice to see so many different aspects of the software in the symposium. We were very happy to take part in the symposium, and basically we were able to present our results on the prostatic artery embolization, and in our trial we saw that we had 2 times quality reserve on the image quality. Basically the contrast to noise ratio was very, very good, and we were able to see that there's some potential for radiation dose reduction and even contrast agent reduction. And in the qualitative analysis of our readers, we saw that the preference was significantly towards the DVA images, only in the context of bigger vessels like the aorta. The difference wasn't that relevant, so we saw that nearly there was no preference over the normal DSA.
Thank you for your detailed answer, and I'm afraid we have reached the end of today's session. Thank you to all our listeners for joining us today, and big thank you to Dr. Leona S.Alizadeh from University Hospital Frankfurt for sharing her insight and wisdom with us. As always, if anyone has any question or comment about what we have discussed, be sure to get in touch with us. We're looking forward to catch you all next time.
Goodbye.
Bye.